Good morning, everybody. This is Jody Brown. I'm the Executive Director of the Parkinson Association of the Rockies. And with me today, I have Glenn Gillian from Boston Scientific and Dr. Jay Schneiders, who's going to talk about neuropsychological testing. I want to really briefly tell you how to ask questions. We are going to hold questions until the end of the presentation, but there are two ways that you can ask a question. The first one is to the right on your panel. You'll see a section called question. You can type a question in there at any time during the presentation. We will also afterwards be able to, if you want to raise your hand, will be a button that you can push that says raise hand. And I will unmute you and you can ask your question live after the presentation has ended. So at this point, I'm going to introduce Glenn Gillian, who will give us a brief introduction to Boston Scientific, and then we'll go from there. Thank you.
Yeah, thank you. So my name is Glenn Gillian, and I am a clinical specialist at Boston Scientific for deep brain stimulation. Myself and my colleague, John Campbell, we work in Wyoming, Colorado, New Mexico, and in El Paso as well. A big part of my job is covering clinical aspects of the position, so surgeries and programmings of the deep brain stimulation device after the surgeries are complete. But today I just wanted to give a brief introduction of Boston Scientific DBS and just kind of when you need to start thinking about it. So deep brain stimulation is a very tough subject for a lot of people and a lot of families, and it's good to start thinking about it and looking at options early so that when the decision to either pursue it or not pursue it comes, it is a lot easier because you've been thinking about it for a while and you have all that information. So really, when medical management is not enough to give you the quality of life that you need anymore, or when medical management, specifically levodopa, is not as predictive as it once was, that's when deep brain stimulation should be on your mind. Now, Boston Scientific is a little bit different. We developed our technology from cochlear implants versus pacemaker technology. So we have the most advanced current steering system, which is able to advance or stimulate areas of your brain that are going to cause therapeutic benefits while steering away from areas that cause side effects. So we're able to advance with your disease and keep that quality of life high throughout the entire disease progression, as high as we can. We have a wonderful website called dbsandme.com, and that's how you get there. Is dbsandme.com. You can take a great survey to see if you're a candidate or not, and you can also type in your information on that contact us page, and it'll come right to me. I frequently have conversations with families and Parkinson's patients and the local resources and anything like that. So please reach out if you would like someone to talk to or just need some more information. But I have the true pleasure today of introducing Dr. Schneiders. Dr. Schneiders, as you all can see on the PowerPoint, or if not in a second, he's a board-certified clinical neuropsychologist, a board-certified clinical health psychologist, and starting back in 1992, has evaluated patients and helped patients with their journey over at Swedish Medical Center and Colorado Neurological Institute of Epilepsy Center. So he has many more accomplishments, which I'm sure that you all will understand with his talk, and quite the expert. So it is my true honor that we're getting to that I get to introduce him and we get to experience this today. So Dr. Schneiders, thank you so much.
Thank you, Glenn. Appreciate it. I'm sorry, folks. It looks like, whoops, I've got Glenn there instead of my PowerPoint. Hold on, I'm going to push Glenn. We're having a little bit of Macintosh Apple difficulty here in terms of the camera, but I'm hoping everyone can hear me and see the PowerPoint clearly. Be sure to touch.
Dr. Schneiders, we can hear you and we can see the PowerPoint. Glenn, if you want to turn off your camera.
I put him on the side. It's okay.
Okay, perfect.
Yeah, thank you. And any of the audience, be sure to let one of the folks know if there's any problem in seeing this along the way. And so, I made an extra effort to shave today and put on a nice tie and shirt, but I'm sorry you're not able to see all that pristine beauty that I brought you. But we'll hope that the PowerPoint does the trick. Glenn, I think, said it best. I've been seeing patients with various different kinds of neurological problems and medical problems for years. I did solid organ transplant for 8 years. I've done inpatient work with schizophrenic patients, and for about the last 20 years, my emphasis has been complex neurological disorders like Parkinson's, Huntington's disease, essential tremor dystonia, and epilepsy. So I don't do forensic work, court work. I'm not an expert witness, and I basically take care of patients. So let's get going here. My website is on this first slide if anybody has more interest in my background. Oops, let's see how we do this. All right. I want to start off by saying I'm a dinosaur. I was trained back in the late 1970s and early 80s. There are days I feel that old and days that I don't. Today's a pretty good day. But I do practice somewhat differently from a lot of the new and young neuropsychologists. And I just mentioned very quickly that I do a doctor to patient kind of pretty individually tailored approach. You know, when I was trained, if you went to the doctor, you saw the doctor. Nowadays, we use nurse practitioners and psychometrists in my field, or PAs, fairly regularly to provide most of the care. I was trained differently, and so if you come to see me, someone like me, you see me rather than a mid-level person. And mid-levels can be very good. I don't mean to cast any aspersions, but I do practice somewhat differently in that respect. I want to mention just basically where neuropsychology came from. When I was in training, I like to think of it, we did have running water and electricity back in those days. It wasn't the Stone Age, but it was close to it. And virtually every year, we learn more about the brain and about how it's functioning. But neuropsychology probably could be thought to initially appear in the world in the early 1800s with something called phrenology that was come up with by a guy named Francis Gall. And this is a picture of how the phrenologists thought about the brain. They were right that different parts of the brain did different things, and they were among the very first to realize that. However, if you look at that map, it's all made up. I mean, they looked at bumps on the head, they looked at the shape of the head, and they thought that each of these different areas was immediately underneath the skull, and it wasn't the case. But it was a way to think about the brain being not just all working at once, but having different parts to it. Phineas Gage in 1848 was a pretty unfortunate fellow. He was a railroad construction foreman, and during his work, there was an accidental explosion, and it drove an iron rod through his head, specifically through his left frontal lobe. Phineas Gage lived, and he lived for another 12 years, although his personality was changed tremendously. And this was maybe I would think of as kind of the second main step in neuropsychology, because people realized that there were specific changes in specific parts of the brain. And here's poor Phineas with the rod he's holding in his hand and a picture of where it was in his brain. And that's a pretty bad injury, but he survived. And again, he was never the old Phineas he started out being, but he was functional in most ways. In the 20th century, we saw the world wars unfortunately provide opportunities to better understand the brain. Kurt Goldstein in America and Alexander Luria, who was the great probably progenitor of neuropsychology from Russia, had the, again, unfortunate opportunity to see very specific bullet wounds and what kinds of problems they caused. And so Luria, he truly was a genius, and he mapped out the different areas of the brain in a way long before we had MRIs or CT scans, and his work was absolutely brilliant in setting the stage for contemporary neuropsychology, which then was kind of tuned up by what we call empirical psychology, and that's the scientific study of the brain through the 20th century, where we began to do experiments and studies and research on different conditions and led to current understandings of neuropsychology. So what's a neuropsychologist? Neuropsychologists have a doctoral degree, a PhD or PsyD in psychology, which takes 4 to 5 years of intensive study, then a year internship, residency or fellowship for a couple of years, and then there's board certification. Very similar to neurology. Neurology has doctors of medicine or osteopaths, 4 years, 1 year internship, residency fellowship, 2 to 4 years, board certified in their field. So it's absolutely parallel to neurology, and we do have subspecialties. And as I said before, movement disorders and seizures are mine currently. So neuropsychology studies disorders of brain functioning. Obviously, the neurosurgeons are the salami cutters, so to speak. I mean, they do the operating, and you don't want a neurologist or a neuropsychologist to be opening your skull, and conversely, you don't want a neurosurgeon trying to figure out what the functional differences are in your brain. We all do different things. We're all trained in the same neurological sciences, but while the neurosurgeons do the cutting and the neurologists do the medical prescribing and the structural kinds of issues, stroke and figuring out what medicines to give for different things, neuropsychologists deal with function, brain function. And there are different ways to think about this, but the most general way to think about what we do is we look at how the different areas of the brain are operating. Are they operating the way we want them to, or are there changes? And this first diagram shows you the larger different areas of the brain that we look at. Way in the back, you see at the occipital lobe in red, that's where vision is, which is kind of an odd thing because the eyes are on the other side of the body there under that word temporal, or above that word temporal lobe. The parietal lobe is a kind of sensory integration area. We see the blue area is the frontal lobe. I think of that as a little bit like in The Wizard of Oz, the little guy behind the screen that's operating everything. The frontal lobes do all of the executive function of the brain, which we'll talk about later. And then the temporal lobe in yellow is where on the outside, or the main part of the folds there, we see speech and language function. And then inside that yellow to bordering with blue, green colors, in the inside, in the temporal lobe, is where memory is found. Now, that's a general way to think about it. In neuropsychology, we see both on here the left brain and in a moment the right brain. This very specific kinds of areas that are important in human functioning that we can look at. And so neuropsychology we can't pinpoint almost at all one of these specific areas with a particular test. There are a few exceptions. So we're looking at connections, we're looking at general areas, and we work in two directions. We take our basic evaluating instruments and we use them on patients to figure out what's going on, but we also look at what patients bring us in terms of, this is what I find problematic, this is what is bothering me, this is what has changed. And then we can go to these kinds of maps and think about which areas of the brain have been disturbed or have become problematic.
Yeah, she went and got some stuff this weekend.
I'm hearing some talking in the background. I'm going to wait for questions though until the end. So you get a report at the end of a neuropsychologist's examination, and what we typically address in reports are the following things. So you're going to see a section on speech and language function. Now, the biggest problem that people typically report across neurological problems is coming up with words, finding words, or coming up with names. Now, there's a normal part to aging in that. I know I become incredibly frustrated. You know, we'll sit around the doctor's lounge on Monday and none of us can remember the name of the movie we saw yesterday for the first couple of tries. So in normal aging, it's very common to have more glitches with coming up with words, with names, even familiar ones. The important thing is that in normal aging, that's not impairing. It doesn't really become something that we start to worry about. It's just frustrating and annoying for the most part. So in a neuropsychological evaluation, we're looking at both expressive language, how speech comes out, but also receptive language in terms of how people's comprehension and understanding goes. In a neuropsychological evaluation, in addition to coming up with names or words, we can see problems in grammar. Those are more common in Alzheimer's disease. In prosody, which is the melodic tone of speaking. So for example, someone with a stroke in a particular area of the brain that controls that might talk like this in more of a telegraphic fashion. So the melody is assessed. Cadence, or the smoothness of speech, is looked at, and also volume. And volume is a typical problem for people, for example, with Parkinson's disease, whose voice tends to become softer and harder to project and to hear even. Visual, spatial, and constructional function. How does the brain perceive spatial relationships? What's the ability of the person to analyze visual space? We look at that. Lots of puzzles involved in that. Information processing speed. Everybody's information processing speed gradually slows as we get older, but not in, again, a way that would be impairing to us. It would be a serious problem in our functioning. Parkinson's disease, however, can fairly significantly slow processing. So we see more of a considerable change in that typically in Parkinson's. We have both response delays. So if someone wants to answer a question or start to talk, there may be a delay before speaking, and that's a little slower. And also just a slowed ability to make sense of lots of stimuli or input. Very common concern people bring to me is that they can do fine in a conversation individually with someone, but if there are 3 or 4 people talking, it's really hard to keep up with all of the different flows of thinking and talking. Attention and concentration is something we look at in an examination on neuropsychological testing. How well can people focus their attention? Are they distractible, either to sounds or things in the visual periphery, in terms of internal thoughts? So sometimes people have trouble inhibiting different kinds of jumping from thought to thought from the inside, and are more distractible to their own thinking processes or emotions. We can also focus on how well do people sustain their attention. That's always a problem in real life if it's impaired in any way, because staying with a task, whether it's working on an email or doing the laundry or whatever it might be, cooking a recipe, if we can't sustain our attention, we don't get things done very well. General intellectual function, I'll talk about in a little bit, but generally just how is our overall cognitive functioning? We look at that in a couple of ways. And we also look at personality function, which I'll also talk about more in a moment, and a couple other things. So you see there's quite a bit we look at in a typical evaluation. Memory function, obviously, is a big deal for people who come to see neuropsychologists for testing. There are various kinds of memory. I don't even have all of them listed here, but we have auditory verbal memory. Do you remember conversations as well? Can you remember a list of grocery items well when you go to the store? Visual figural memory is remembering what we've seen. So for example, a lot of us have kind of crummy visual figural memory. All our lives, we might have a little more trouble remembering how to get someplace if we haven't been there in a long time. Our directional sense, getting lost in familiar places is a bigger problem. Remembering where you parked your car, these kinds of visual memory issues we can look at in the office. Working memory is the ability to shift from one thing to another while we're operating on it. So for example, the classic in-world example is you're cooking at the stove, the doorbell rings. So you put the pan on the back burner, you go to the door, you talk to the annoying person who's come there to sell you something, and now you have to remember to shift back. Your brain has to remember, oh, I was cooking, and go back in. And so working memory is the ability to do that kind of thing. And then there's old memory. How well do we remember things that go back in our lives? So information we might have learned, who was the first president of the United States, and that kind of thing. There are some other aspects of memory, specifically autobiographical memory, remembering things that have happened to us that can change as well. This is a little less frequent in movement disorders and more common in epilepsy, where people actually sometimes just don't remember a conversation until it was jogged, or having gone to a party unless someone tells them, oh yeah, don't you remember this? And in very serious cases where autobiographical memory is affected, we can see people. I had a patient in my office with his wife, and she commented on a cruise they'd been on the year before. And he said, we didn't go on a cruise. And he had no memory of being on the cruise at all. And even when she showed him photographs on the phone, he had no memory of it at all. So that's an extreme example of a problem with autobiographical memory. So all these things are tested in a neuropsychological evaluation. And then executive function is particularly important in Parkinson's disease and in other movement disorders. Executive function, you remember I said, is controlled in the frontal lobes of the brain, the frontal part of the brain. And what the frontal lobes do is they help us organize our behaviors. So we think, okay, I'm going to, you could, a very complex example, something I could not do would be, okay, I want to repair my lawnmower, I'm going to take it apart, and these are the things I have to do that. But organizing behaviors can be as simple as following a recipe and organizing what you're going to do in the steps. So planning activities or behaviors. And then also anticipating consequences of things. Again, a simple example would be if you're making something, a recipe, anticipating that if you turn the burner on high to heat the oil, you need to turn it down or you're going to burn something. So anticipating the consequences of what we do and how we behave. Monitoring our behavior, kind of paying attention. Are we making mistakes as we go along? Those are all things the frontal lobes do. The frontal lobes also initiate behavior. And I'll talk a little bit more about that in just a moment. There's an area of the frontal lobes that is involved with complex attention, focusing and sustaining attention, and shifting from one thing to another and back. You get interrupted with something, can you go back to the task that you were involved in and pick it up where you were before your interruption? And then also controlling and modulating behavior. The frontal lobes, when they're damaged, we can see very significant and serious behavioral disorders and problems. And they can be less serious, but still noticeable and troublesome to people in neurological illnesses as well. So all of those things are looked at in a good neuropsychological evaluation. I want to just touch on a couple of these a little bit more intensively. When we think about the frontal lobes and testing for controlling and modulating behavior, there are two different general things that the frontal lobes do that get affected. In Parkinson's, for example, we see problems of initiating behavior. So people will seem more apathetic. Their brain's drive state, their oomph, doesn't seem to be as great. They have trouble getting going. And this is a neurological problem, not a psychiatric or psychological one, for the most part, at least as I'm thinking of it here. You can certainly have these things for psychological reasons, but neuropsychological testing or evaluations will be thinking about these in terms of what the person's neurological or medical state is and whether that affects these things. So in Parkinson's disease, one of the issues that I see quite often is that not just family members and sometimes doctors, but patients too, can assume that the lower motivation that they are experiencing, or the trouble they have getting going, or what really seems like apathy, is a sign of depression. Now, you can have depression too, but it's not uncommon to see apathy, and it looks like depression, but it absolutely isn't. The most extreme example of this was those old, terrible operations that they did in the 20th century called lobotomies. And a lobotomy, brace yourself, it's not a pleasant thing to describe, was basically they took something like an ice pick and just stuck it into the front of the brain and just shredded the tissue. And what that did was leave people very, very apathetic. They didn't initiate behaviors. I saw one of probably the last living survivors of lobotomies when I was in training. And I remember this was a person who would just sit and not do anything. Now, you could say to the person, would you like to go to see a movie? And they'd brighten and go, yeah, I'd like to see a movie. But you'd have to say, well, you have to stand up now. And so they'd stand up. And then you have to say, okay, you've got to walk over here. And they'd walk. Initiating the behaviors was something that became significantly impaired because the frontal lobes weren't working well. And so we see a milder version of that with people, again, with different neurological problems. Inhibiting behavior is another problem. And this is, again, something we see in Parkinson's fairly commonly. We can see what we call impulse control disorders. And these can certainly be pushed by different medications. They can be made much worse by some of the dopamine agonists in various people with Parkinson's. Not every person and not every medication combination causes this, but it's not uncommon to see. And impulse control disorders can be fairly, I guess I'd call them mild in comparison to the severe ones. But you can see people who blurt out things that they wouldn't have said. You know, with a child, you might say, that's your inside voice. Keep that in your head. You don't say to the, you know, the man on the street, oh, that's a big pimple on your nose, isn't it? That's something you keep in your head. You inhibit that thought. And in neurological conditions, the frontal lobes can be affected such that people will suddenly find that they're saying or they're doing things that they would ordinarily have inhibited. This can become very severe. And again, it's rare to see the severe forms, but I've seen a patient in the past, for example, who bought, I believe it was 7 cars in one day, new cars. And that's hard to walk back once they're driven off the lot. But the impulse to do that, or the impulse to gamble online in people who never had it before, never felt it, that's it, a disinhibition, a difficulty inhibiting behaviors. And then again, in Parkinson's, we can also see something called behavioral inertia or punding. And that's when it's hard to leave something. The frontal lobes don't shift off of something. So a common complaint in my office will be a spouse saying, you know, I call him in for dinner and he's at work, he's playing solitaire in the computer, and I have to call him 10 times. And then I have to go over and physically bring him in for dinner because he can't stop doing it. And so continuously doing things and feeling sticky, that you got stuck in them and can't shift off of them when they aren't particularly meaningful things or critical things, is another example of how the frontal lobes can get glitchy in terms of controlling behavior. Now, what about intelligence? I'm not going to read through this, but just to say that intelligence is something neuropsychologists think about. And it's a kind of a global ability of the brain to solve problems and function and to think. And a lot of patients want to know, am I going to get an IQ? Are you measuring my IQ? IQ is, it's the intelligent quotient, and it's a score that is thought to represent the ability to reason and solve a host of different kinds of problems. And it's tested, there's something called the Wechsler Adult Intelligence Scale that's been used in various forms for decades. And a brilliant guy named David Wechsler came up with about, I think it's 14, I might be wrong, it keeps changing. And forgive me, I'm an old guy. I think it's about 14 different subtests, so putting blocks together and repeating numbers and defining words. And all these different things are administered and thought to be representative of intelligence. And an IQ then is developed based on the scores for these things. There's a verbal IQ, which is thought to represent verbal functioning or the dominant hemisphere of the brain. And then there's a performance IQ, which is thought to be more visual and kind of motor based. In fact, these things really turn out to overlap more than we would like them to have done. And then there's a full scale IQ as well. Now, a reminder, I'm a dinosaur. I don't typically assess for IQ functioning. IQ is kind of an imaginary number. And if you think about 14 different subtests and then dividing those into 2 groups and then taking those numbers and coming up with one number that is supposed to define a person's or address a person's so-called IQ, is kind of imaginary. Yeah, it's sort of accurate and it's sort of right, but there's lots of different kinds of intelligence. There are people who are intelligent in terms of playing chess or of taking lawnmower motors apart or repairing cars, or emotional intelligence that may not show up very, very highly on an IQ test. And so I'm a dinosaur. I really don't like to get simple numbers and then try to define people or label people based on those. An IQ number can be helpful and it can be generated, but typically I don't do it in most of my neuropsychological reports. In fact, the great grand lady Muriel Lezak is her name, who trained generations of neuropsychologists. When she gave her presidential address, I think it was 1986, to our big national body, the title of her talk was IQ RIP. Let's kill this silly number off. Now, a lot of neuropsychologists still use it. And again, for the reasons I gave, I'm not a big fan of it. So why would you get referred for neuropsychological testing? Well, obviously the simple answer is to assess the degree to which, if at all, a person's functioning has been adversely affected by their neurological condition or medical issues, psychological issues, stress, substance use, or medication. How has your brain been affected? Now, it's also useful to obtain a more accurate diagnosis. For example, with Parkinson's patients, I'm often referred patients by neurologists to tell whether a person has Parkinson's disease, mild cognitive impairment, or whether they have Parkinson's disease dementia. And sometimes people have neither. They have normal aging and the effects of other kinds of things, which I list down there below. We call it multifactorial comorbid conditions. Look, sleep is a huge factor impacting cognition. When I don't sleep, I can't think well. I don't organize well. I don't focus my attention as well. And lots of sleep disorders have serious effects on cognition and neuropsychological testing that can look like something like Alzheimer's disease. Alzheimer's versus pseudodementia is another thing that diagnostically we look at. Does the person have a neurological change in their cognition, or is the change due, let's say, to a severe depression? We also can be referred for neuropsychological testing to assess whether our brain changes are progressing over time. As I said, do we change from a mild cognitive impairment to more of a dementia? Dementia simply means a progressive neurocognitive disorder that involves a decrease in memory function and some other ability, so like speech and language or visual spatial analysis, executive function, something like that. So we can say, okay, this is where a person is today. I want you back in my office in 6 months or a year, and let's see where you are then and see if it's progressing. And that can help us both diagnose and also treat such conditions. And just simple, straightforward things can be assessed over time. Is it time now to add a symptom modifying medication, a memory medication or not? Has the condition worsened so that additional help might be needed in a person's life and home? His work or driving continue to be thought safe and reasonable, although we don't do driving exams per se. So all these things can be assessed when we look at a person's functioning over time. And then there are the special cases for neuropsychological testing. The preoperative assessment or clearance. Patients are referred for deep brain stimulation surgery and epilepsy surgery. And the reason for DBS surgery pre-op assessments is that the DBS can and commonly does have some effect on a person's cognition, and it can have effects on a person's behavior and emotions. And we want to make sure that to the extent possible, a person has enough what we call cognitive reserve. Do they have enough cognitive functioning at a level that if those and when those, we hope, minor changes occur, that it doesn't impair their function in some way. So the neuropsychology testing is designed to be protective and to see and to make sure that a person's safe for the surgery in a cognitive and psychological and neurological way as much as possible in terms of making sure their function will be okay after the operation. There are people who are referred for independent medical exams or independent psychological exams, disability exams. Disability companies send patients to neuropsychologists all the time. Sometimes competency evaluations are requested. And I always tell doctors that competency is a term that is a legal term, and doctors cannot, literally cannot assign it. We can say a person's not able to function independently or safely, but competency is a legal determination that a court has to make. But still, neuropsychologists' input from our testing can be helpful in understanding if a person's disabled or how much, or whether or not they are really safe operating in the world on their own. For example, a person with late onset or late Alzheimer's disease. And then finally, we can sometimes do neuropsychological testing for just general baseline reasons. There's no particular cognitive problem presently going on, but there might be some reason to worry that down the road there could be, and we want to have a set of test results that we can compare later on. So a person, for example, who's not really showing lots of problems currently, but whose brother and sister have shown an early dementia, and father did, and uncle and aunt did, and grandparents did, we might want to have a baseline when they're still functioning perfectly well so that we can assess changes as soon as they occur. Now, what's an evaluation like? Again, I'm a bit of a dinosaur. If you come in and see me, I'm going to do the exam rather than having a mid-level person do it. Different neuropsychologists operate differently. I'll talk about that. Now, in the old day, the very old days, you can see the phrenologist there with a caliper and checking the bumps on the patient's head. And we don't do that anymore, thankfully, a couple hundred years ago. And while a neuropsychological examination is not a trip to the beach and a nice, drinking Mai Tais and eating bonbons, it's also not this. People who get neuropsychological evaluations should not imagine they're going to be treated harshly or coldly, or they're going to be judged as people, or their brain's going to be judged. At least the way I practice it isn't, and I can't imagine any good, well-trained neuropsychologist approaching a patient like that. Different doctors, however, do neuropsychological evaluations somewhat differently. There are a standardized set of tests that virtually all of us give. There are a couple of outliers in the community here I can think of who don't use the standard tests, but it's very rare not to see that anymore. So there's some general conventions that virtually all of us use. Some neuropsychologists, as I've mentioned, use a mid-level person, a psychometrist, to administer and score the test. So in those cases, you would see the neuropsychologist for a brief interview, and then you'd go off for a number of hours with a psychometrist who'd do the testing and give the numbers to the doctor. The amount of time in a clinical interview, which is part of it, also vary. I do quite extensive clinical interviews, which are basically talking to people, conversations about function. where some neuropsychologists do very little and rely entirely on paperwork, I'm sorry, largely on paperwork. Now, neuropsychological testing is only a part of a neuropsychological evaluation or assessment, in my view. The formal testing at the desk can take as little as an hour or less, and sometimes, depending on the need, it can take most of a day. I always tell patients to be reassured. You're going to be able to take breaks. The testing is paced, and I don't want my patients leaving here feeling worse than when they came in. Everybody's different in how they experience the testing, but a good neuropsychologist and certainly a psychometrist should be paying attention to that. And you shouldn't be on the clock. You should be, I want to see my patients do their very best in the evaluation. I know they're having problems or they wouldn't come to my office, but I want to see what their brains are capable of doing under the best circumstances. So the examination process from my standpoint should be humane, and it should be therapeutic even. People should leave feeling, even if it's tiring, feeling pretty good about the process. The clinical interview I mentioned before varies considerably. I like to have family members come in because we all have different perspectives on things. And it's up to the patient if they permit that or not. But I think most families and patients feel good about a combined interview. I can always see people and talk with them individually and privately as well. And I leave it up to the patient to decide. My clinical interviews, again, I'm a dinosaur, they're quite extensive because I want to find out all the different things that can be affecting you or affecting a patient that could be contributing to problems. Sometimes a person with Parkinson's isn't having any kind of Parkinson-related cognitive problems or neuropsychological problems. The problems they're having, if to the extent they exist, are happening from some other kind of problem, like a sleep disorder or a medication side effect, something like that. Now, personality assessment is a part of a neuropsychological evaluation, and nowadays many neuropsychologists will give quite lengthy paper and pencil, true-false kinds of questionnaires, and there are two of them listed here. I'm old school, and I feel like if you have a really good conversation with people and you talk in detail and with some subtlety and some empathy, you're going to get much better information about a person's personality from a conversation or an interview with them than you are from an objective 500 question true-false test. There can be reasons to use those, and a lot of neuropsychologists use them as a standard part of the process. I typically don't, and again, we're all a little bit different in that. In terms of understanding what the test results mean, some neuropsychologists heavily depend on scores and numbers. Others very intensively depend on more qualitative factors, how the person has acted or behaved, how they've answered things. One time, one of my old teachers sat down and he figured out on a block assembly design task, he thought there were about 25 different ways to quote, fail that or do poorly at that. So just getting a number doesn't mean much unless you put it in context. So I think most neuropsychologists are somewhere in the middle between emphasizing scores and looking at qualitative kinds of issues. I always tell patients that to be kind of aware that they're going to hear words in a neuropsychological test report that can feel pretty lousy. There's a particular word that neuropsychologists these days use quite often that I like to think I've never used in a report. Now, I'm not trying to say I'm God's gift to neuropsychology or patients, or everything I do is the right way to do it. But you're hearing from me today, so this is, again, my way of thinking. I don't believe people have deficits. And the word deficit is tossed around in these reports a lot. And so I think, again, when people read impairment or deficits as opposed to things like difficulties or problems, it can feel pretty lousy. The score descriptions, people get a score in a particular area. It might be severely impaired or profoundly impaired. And it's very important that people understand this is not, you're not a profoundly impaired human being. the score on this test was maybe impaired. So having a doctor who thinks, or at least will talk with you about these types of conclusions in ways that don't make you feel bad, for good reason, genuinely, I think is important in neuropsychological testing. And finally, different neuropsychologists may emphasize or focus on a patient's strengths more or less. And I think that's an important part of an exam. It's not all about what's going wrong. It should be focusing on what's going right too. Okay, how do I choose a neuropsychologist? If your medical doctor says it's up to you, here are 5 different people. Well, start with the website. A lot of websites will convey what we're like as people. They'll have information about the exam itself. And secondly, I think it's important to ensure that the doctor you're referred to, the neuropsychologist you see, has a specific expertise in your area of concern. This can vary tremendously. Most neuropsychologists are very comfortable and see lots of patients with dementias and Alzheimer's disease, but they may not have a lot of experience, say, with Huntington's disease or with certain kinds of strokes. So neuropsychologists have different specialties, just as neurologists do. And then again, you can ask up front, does a neuropsychology doctor use a psychometrist or a mid-level, or does the doctor test him or herself? And then finally, board certification. Board certification is a little bit newer in psychology, but neuropsychologists are commonly board certified now or not. It doesn't mean that a neuropsychologist who does not have board certification is not a good neuropsychologist, but it does these days raise the question about why that person would not have gone through the certification process. And there are arguments both ways on this, but board certification requires you have to submit your examples of your clinical work. They're evaluated by a jury of your peers. You have to go in and do an oral examination where you're presented a case, and ethics exams. Basically, they fly all over the country for this stuff. And so basically, it's kind of a floor level determination that a neuropsychologist has been trained in the appropriate way, the training is solid, and their performance on basic evaluation measures of themselves is decent. How do you prepare for a neuropsychological evaluation? Look, the preparation is just to feel as comfortable and good as you can. If you can sleep well, that's probably the most important thing. Not to worry about the evaluation. And then medications are another thing. Follow your doctor's orders. Take the medications you usually take, unless there are things like, Xanax or Valium that you might take only as needed. And it turns out that taking medicines of some sorts like those can actually make the neuropsychological test results worse. There's some studies that show that it's better to be highly anxious than it is to be on some anxiety medications. But again, you can ask your physician about that. But all regular medications, prescribed medications, blood pressure, seizure medications, Parkinson's medications, should always be taken as directed. And then finally, nowadays, a lot of patients are using marijuana, and marijuana does adversely affect cognition and thinking, and certainly at least on the day that you're tested, don't start off the day with a joint. Try not to think of neuropsychological testing as performing. That's at least my view of it. You're not performing for me, and I hope you're not performing for you. Think of it as making a map. I'm sitting making a map of how your brain's functioning. If I made a map of a forest, the forest couldn't fail the map. Well, it couldn't pass the map either. It's just a map. And that's what I want patients to be thinking about. At the end, you should expect to get a copy of your report and have an opportunity to go over it and discuss what the doctor came up with for you. You should have a clear idea of any diagnosis if one is made, and what follow-up recommendations are for treatment or interventions. And you should also understand if and when it's appropriate to come back in. Again, I'm a bit of a dinosaur. I take care of people over long periods of time for their neuropsychological needs, behavior, emotions, cognition. Some neuropsychologists see themselves as testers and as consultants only. And so again, it's a little bit of a crapshoot, frankly, about what the orientation of the doctor is going to be. Sometimes websites give that information, but you can also ask up front, are you somebody I'm going to be able to follow up with and be taken care of and be seen by, or are you just seeing yourself as a consultant who sends data off to my referring doctor? So again, there are different ways to look at that. I guess that's the end of my talk. We've got about 10 minutes for questions. I'm hoping that I'll be able to hear one of the folks get back online here, maybe Jody, to let me know if there's some questions.
Thank you, Dr. Schneiders. That was such an informative presentation, and I like that it was laid out so simple and easy to understand. That was perfect. Thank you so much.
Well, thank you for that.
Yes, that's great. It was just wonderful. So we do have time for questions. I'm going to wait for questions to come in. Remember, there are two ways to ask a question. The first is to go to the question tab on to the right, and you can type a question in, or you can raise your hand and I can actually unmute you and you can ask the question live. I think Glenn is still with us. Glenn, if you want to come back on, you can ask questions about the neuropsychological testing, or you can ask questions about general DBS, and Glenn would be able to answer those for you. So while we're waiting for some of the questions, I did forget to announce that we do have a couple other seminars coming up, so I'll talk about that very briefly. The next seminar we have is on Wednesday, June 23rd, and that is what are my options when PD medications aren't enough. That is also a Boston Scientific sponsored webinar, so we'll be very focused on DBS and what to expect with DBS, so I think that's going to be a fantastic webinar. Dr. Seth Carius is speaking for that. The next one is hallucinations and delusions in Parkinson's, done by Dr. Samantha Holden, who just does an amazing job at breaking that topic down. That will be sponsored by Acadia. And then we do have our third module for our PD 101 series, and that is going to be exercise for Parkinson's, and that is on June 15th. So to register for any of those, just go to our website, www.parkinsonrockies.org, and you can get registered for those.
Jody, can I make
yes.
just one? I forgot to make a comment at the beginning, and we're supposed to do this. I have no conflict of interest here in terms of any remuneration by any company. Boston Scientific is not reimbursing me for this, so there's no skin in the game in terms of medications or devices or anything like that. Just wanted to make that comment.
Thank you. We appreciate that. And we're really sorry that we missed your very spruced up look today.
Oh yeah, I'm wearing a great tie. It has a little picture of a pit bull with a red heart in it. So
oh wow,
we'll have to do that next time.
We missed out on a lot. Well, believe it or not, there are no questions. So I think you did such a good job of laying that out that we don't have any questions right now. We really do appreciate your time today, and we will get a copy of these slides, so we'll send it out to everyone who registered for this webinar. Also, you will be getting a survey, so please fill out the survey. Your input is so helpful for us in determining what we need to do as far as our next educational events and what it is that you want to hear about. So please feel free to send that out. I'm going to do one more. Oh, we've got a raised hand. I'm going to do one more check and see if I have a raised hand. Let's see. I do have a question. See, we just have to give it some time. Okay. So question number one from Jean. If I came in for a pre-DBS neuropsych eval, about how long would I be at your office? I have PD and I'm 63.
Again, I don't have a cookie cutter approach, so I tend to be individualizing my appointments. What I do is I would get a hold of the referral note from your neurologist. I would say that most DBS appointments, pre-DBS appointments, can be done in an afternoon. I'd see somebody at 1 o'clock, let's say, and we just go the afternoon, and generally we're done by 5. It can vary. People who have more complex clinical issues, if they're neurobehavioral or side effects or sleep or psychological factors, might add an hour to that, and I might schedule it, let's say, from 9 to 3 with a lunch break. So it kind of varies, but we always let people know up front what we expect on that.
Great, thank you. Patrick has his hand raised. So Patrick, I'm going to unmute you and you can ask your question. Let's see. Maybe I'm going to unmute you. Okay, so Patrick, you need to unmute yourself now.
There you go.
There it is.
I just wanted to pass along appreciation for the presentation, the depth of knowledge that you shared, and just the wealth of the coverage. I recently went through an examination, and currently I'm working with it. You know, had to take advantage of the information that was gained from it. Would you comment just a little bit of patient responsibility to take advantage of the information in the reports, I guess is one way of saying it. Could you comment on that a little bit, though, and how to put it to get more value out of it?
Absolutely. Thank you. And thank you. That's very kind feedback, and I appreciate that. A neuropsych report, as I say, might have anywhere from 3 to 5, you know, sometimes more and sometimes just a couple recommendations at the end. And they might be things for it's important to get a sleep study, or talk to your doctor about getting a different medication or changing something. We do not prescribe medications in Colorado. I want to state that, but we do make recommendations, and that's part of what physicians want us to do. So there may be 4 or 5 or 6 recommendations. It's very important that patients follow up with those. At least, you know, my thoughts, I don't have, again, cookie cutter a list of things for people to do. I can only speak for myself, but my recommendations, I like to think, are thoughtful and very specific. The problem we all run into is that everybody sees about 5 different doctors. You see a primary care doc, a neurologist, maybe a neurosurgeon, a neuropsychologist, maybe somebody else in addition, and everybody's doing a piece of it. That's why I always offer to get together with people in 3 months or 6 months for just an hour, and let's make sure you haven't fallen through the cracks. Let's make sure all these things have been followed up on, whether it's a hearing test or whatever it might be. I think, Patrick, you make the whole point, which is just simply, it's really important to follow up on things. If for some reason it turns out not to be a useful journey or a useful recommendation, that's okay, but it probably should be brought back to the doctor to talk about, to make sure that whatever the problem was that the recommendation was aimed at gets taken care of in a different way. So I just think, Patrick, your point is just following through on those things is really important.
Thank you.
Thank you.
Thank you. And then not really questions, but the first is there going to be a recording? And yes, this seminar is recorded. It will be available on our YouTube channel. It's usually available within 2 to 3 days after the presentation. And then also Carolyn, Dr. Schneiders said, excellent information and presentation. Thank you. So
Thank you.
Again, I think that this information is really informative to people, and it's something that people don't understand. So I think this is a great topic, and we will definitely do this again at some point. And with that, there are no other questions. So Glenn and Dr. Schneiders, I really appreciate your time today, and thank everybody for attending the webinar, and enjoy the rest of your afternoon.
Back at you. Thanks so much for inviting me.
Thank you.
Yes, Sam, thank you so much.
Okay, thanks, Glenn. All right, I will chat with you guys later. Have a great afternoon. Bye-bye.
You too. Bye now.